Hey everybody, it's Dr. Wood, and today we're going to be talking about Chapter 13, or percutaneous routes. So what does that mean? Basically, we're looking at any medication that gets absorbed through the skin or a mucous membrane. And so some of the specific routes we're going to talk about include buccal, sublingual, topical, and then transdermal. Again, the nice things here that they can either provide for local effects, so a lot of transdermal products or topical products will do this, and then they can also provide systemic effects depending on how well the drug gets absorbed into the system. So topical medications, typically, depending on the case, will either be local or more systemic, and it's important to apply it as prescribed. So if it says 3 times a day, make sure you do it 3 times a day here. Make sure to wash off the skin beforehand. That way you can try to prevent any contamination or anything like that, or anything preventing the drug from getting absorbed. You don't want to use soap necessarily, unless the skin is like very dirty, mainly because that soap can actually have some issues and actually inactivate some products. So that's one thing to note there. And typically, the more better hydrated, or the more well hydrated the skin is, the better it's going to make for drug absorption. If the skin's really scaly and dry, it tends to prevent drugs from being absorbed very effectively. Lots of different varieties that are out there, so powders, soaks, compresses, etc. You can find that typically for using like a warm soak, you typically don't want it to go more than 115 degrees Fahrenheit, mainly due to the fact that it can be pretty painful to the patient. So kind of as hot as they can tolerate is something to note there. Sometimes wet applications of things, these are good for like really, say dry, scaly skin, as I kind of mentioned. They may actually have a mild astringent, which causes the skin to contract to some degree. Can be useful to try to keep in that moisture there. And also note that in cases where you want to make sure to keep the drug in contact with the skin and keep it moist, sometimes by wrapping it in plastic can actually help out with that. So something you may see being used occasionally. More common than not, you're going to be dealing with creams, ointments, gels, and lotions. These are the most common topical products you're going to find out there. So the things that differ between these are mainly going to be sort of the feel of the products, and that has a lot to do with if they're more water-based or oil-based. So for instance, with creams, they tend to be a little bit more water-based. They wash away more easily. They don't leave as much of a greasy feeling, versus ointments being more oil-based. They do tend to have that sort of greasy sort of feel to it, whether it's based on petroleum or lanolin, things like that. Gels may be more based off of, say, more alcohol-based things. They tend to be a little bit more drying. So that's one thing to note with that. It just depends on the formulation you have there. And then you find lotions tend to be a little bit more water-based, tend to be pretty soft. This is probably even easier to wash away than something like, say, a cream might be. Now, what do you need when you're applying topical medications? Obviously, any equipment you're going to require, which I'll give you an example of that in a second. Obviously, the provider's order, the medication is ordered. Gloves are really important. This is something that a lot of people don't think about, but if you're applying medications to a patient, you make sure that you're not getting contaminated with the medication itself. And then anything you need to clean the skin, and any dressings or bandages as required. If you're dealing with medications that are going to be long-acting, like a patch, a disc, or transdermal dot, these are nice because they can act for up to several days. So sometimes you only have to change them once every 3 days, sometimes every 7 days. These are for medications that will then pass through the skin and then into the circulatory system for sort of a continuous sort of effect here. And again, you'll just change the type of patch or disc you're going to use based on the desired dose you want to give. And this is another really important one to handle carefully to prevent someone who is not needing the medication to get contaminated and get some absorption through their hands there. So just to give an example of some common patches and discs and things like that, you can have things like nitroglycerin, which is used for angina or chest pain caused by exertion, estrogen and progesterone, sort of female hormones, duragesic, which is a fentanyl, which is a strong painkiller, even nicotine, when we're using it for smoking cessation, all can come as sort of a transdermal patch or a product like that. So a lot of different options that are out there, a lot of different reasons why we might use this. The benefit, though, is that when it's long acting, can work for several days, and the patient doesn't have to take anything orally. So give you an example of using nitroglycerin transdermal. This is actually a case where we're using an ointment and actually applying it to a pad here. You can actually see you would dose it based off of length. So you would either do like, say, 1/2 inch, 1 inch, etc. And so make sure when you're applying it to make sure to cleanse the skin of any residual ointment, say from the last dose. And then you actually apply it to this paper here and then just slap that on the patient essentially. You want to make sure it doesn't have a lot of hair and scar tissue, because that can impair absorption. Then basically you hold it in place for about 10 seconds or so, and then occasionally you actually put either like tape or plastic or something over that in order to make sure that it stays in place there. Other things you can use include things like sprays and aerosols. Again, you want to make sure to shake these up beforehand because they tend to be products that separate out, so you want to make sure they're nice and in solution there. And basically hold the product about 6 to 12 inches away from the patient, and then spray the fine mist sort of over the affected area, right? If the patient's getting it near their face, just have them kind of turn their head away, and that will help to prevent them from getting a big face full of medication, which can be irritating to the eyes. One special note you want to make about geriatric patients is to not be too forceful when applying it to them, because their skin tends to be a little bit more sensitive, and so you want to observe for any kind of excoriation or any kind of irritation from the medication itself. Switching gears, you're going to have buccal and sublingual medication absorption. Basically, sublingual medications are going to be placed underneath the tongue, which you can see here. These are not to be swallowed. These are typically for drugs that have a harder time being absorbed if swallowed. And so basically what this does, it will slowly dissolve and then will allow for the medication to be absorbed directly there, and it actually bypasses the liver and has very good absorption to the bloodstream. Not every medication can go via this route, but certain ones will do this. The one that always comes to my mind is actually Zofran, which is an antiemetic drug that is very popular. Buccal medications, while not placed underneath the tongue, actually end up getting placed between the teeth and the gums, and then get absorbed from that mucosa there. And again, same effect here. You're bypassing the liver and getting good systemic absorption. Again, medication should be allowed to dissolve completely. Don't want to have them try to swallow it earlier, because that may impede how much drug actually gets absorbed there. For ophthalmic medications, again, a lot of different varieties here, including ointments and drops, things like that. Again, nice benefit with using these is they have nice local action without getting absorbed systemically. So there's not really a lot of side effects besides just what you will see in the eye itself. One thing to note with these is that you want to make sure these stay sterile, right? You can see that they tend to accumulate cooties, especially if you're using it for, say, like an antibiotic, and the patient has bacteria that contaminate the product. They can then recontaminate themselves, and so that's why it's really important to make sure you keep these sterile. Now, when giving eye drops, to make sure to kind of cleanse away any drainage, you want to make sure that you're going to be kind of moving from the inner to the outer canthus, kind of wiping it away, and then make sure to warm the drops up, just kind of in between your hands is fine. And then roughly quarter to half an inch above the conjunctival sac, you'll have the patient kind of pull down the bottom eyelid and actually apply the drop there. Make sure not to touch the eye with the dropper tip, because that's how you contaminate it. Here you can see an example how they're pulling down the lower eyelid and applying the medication directly. Again, notice there's no touching here. This remains sterile. Once you give the prescribed amount, whether 1 drop, 2 drops, whatever the case may be, go ahead and have the patient place a finger over the lacrimal duct, and what that will do is it will keep the drug in contact with the eye for longer, roughly 30 to 60 seconds or so. Make sure the drug works before it gets actually absorbed through that nasolacrimal duct. Now, the process here for using an eye ointment is very much the same. You'll find the dose typically gets expressed in terms of inches rather than in drops, mainly because it's much more viscous and does not kind of flow the same way that a liquid does. But basically, you're going to be applying this the same way. The only difference here is you actually don't need to have the patient cover up their lacrimal duct, mainly because the stuff is so viscous that it doesn't really have any absorption through there. But again, one thing to note with these is that the patients are more likely to have visual blurring, and so it's important they don't need to go drive a car or operate heavy machinery for about 20 minutes or so after applying the ointment. Example how this would look, again, applying it an ointment instead of a drop. Now, going to otic medications, or things you're going to be applying to the ears. This is really important in terms of keeping the medication at room temperature, mainly because if you apply really cold liquids into the ear, you can actually trigger vertigo and nausea. And so another thing to consider as well is whether or not the patient's tympanic membrane or eardrum is intact, or maybe they have tubes in place because they've had frequent acute otitis media, things like that. So make sure that you know that beforehand, because some medications cannot be given if there is tubes in place or if there is a ruptured eardrum. Okay. Other things to know as well is that sometimes what we'll do is use an ophthalmic medication or use an ocular medication in the ears. That's okay, you can do that, but it's really important to know don't use otic medications in the eyes. It's really not formulated for that, and you're going to cause a lot of irritation for the patient. Basically, for the patient to administer otic medications, you're going to have them lying on one side, or at least with one ear facing up. Warm the medication between your hands to get to close to body temperature, and then you're going to administer slowly, holding about ½ inch above the ear here, and then maybe basically aim towards the canal wall rather than the eardrum itself, and then have them remain in that position for 5 minutes or so. That will allow the drug to have good contact with the ear, and then get have a better action than it would be if you just had them stand right up and then just flowed right out. Here's an example of a dropper being used to apply medication directly into the ear itself. Again, by pulling the ear up, that typically is going to allow for a little bit better flow towards the ear canal. Nasal medications are going to be applied either via dropper, atomizer, or aerosol. These last two are probably the more common one. And again, nasal medications more often than not are used for local effects, so things like decongestants and whatnot, but sometimes can be seen used systemically. Typically very, very safe, not going to cause a lot of issues, especially in low doses there. But one thing to note, especially with a drug called Afrin, or oxymetazoline is a generic, using decongestant spray for too long can actually cause a really bad rebound effect. It's something called rhinitis medicamentosa. And this is patients who will end up using it for, say, a week or so, and they try to come off of it, and they end up finding they get rebound nasal congestion. It's actually worse than what they would have beforehand. And so it's really important that they use it for too long. They have to actually wean off of it for roughly a week or two in order to make sure they don't have that rebound effect. Now, when using nasal spray, it's important to make sure to clean out the nasal passages as much as possible. This is make sure that you get good contact with the mucosa there so that it can absorb well. And have the patient tilt the head back and basically occlude one nostril and inhale through the other. Typically, I'll have patients, they'll have them use their left hand to apply a spray into the right nostril and vice versa. That helps to make sure they're not going to be jamming the bottle directly into the septum, and it can cause some trauma there. Basically make sure the tip is centered in the nostril, or at least aimed out to the outside a little bit, and then squeeze to give the medication. Here's an example how you can see this. This would be if someone else was giving the medication versus if the patient's administering it themselves. Again, keep the head tilted back for about 5 minutes or so. That's going to help the drug get good contact with the mucosa, and then don't have them blow the nose prematurely, because then you just lose your drug there. Anything that kind of gets in the back of the throat, if possible, have them cough it out. You may not be able to. Some of it may just get swallowed. That's usually okay for the majority of drugs. Next up, we have inhaled medications. So this includes sprays, powders, gases, liquids. These are all things meant to be absorbed into the respiratory tract. You're going to find they get absorbed very, very quickly here. The most common thing you're going to run into is a metered dose inhaler, or an MDI. And basically, this is going to be a device that is designed to disperse medication specifically to the lungs. Here's an example of a young man using a metered dose inhaler. You can see this is an albuterol inhaler, I believe. Actually, no, it looks like it's a Flovent inhaler. It's actually a steroid patient's using here. But basically, he's using this along with a valve holding chamber. And so this is actually designed to spray the medication into this chamber and then allow him to breathe it in when he's good and ready for it. So you'll sometimes see patients using kind of ancillary devices to help with the absorption. Basically, when they're using an MDI, you're going to be making sure to shake it gently beforehand to make sure it's nice and mixed up and in solution. You'll have the patient breathe out. So take a deep breath, exhale, and then by placing the medication or the inhaler either in the mouth or 1 to 2 inches or so, they'll go ahead and start to breathe in. And as they start to breathe in, that's when you go ahead and depress the inhaler, right? So basically, they're going to shake it up, place it into the mouth. They'll exhale beforehand as they're inhaling in. That's when they're going to press the canister down, and that will deliver the medication down into the lungs itself. Okay, I recommend they hold their breath for about 10 seconds or so. Some patients may not be able to do that, but have them do it for about 10 seconds or so, and that will allow the drug to really kind of get in there and do its thing. If there's a second dose required, meaning like an albuterol inhaler that's like, say, 2 puffs, as is a dose, basically I tell them give 2 to 5 minutes between doses. That will allow the first dose to get in, do its thing, and then allow the second dose to work even better. Okay, it's important to make sure you have them clean it after each use, because otherwise it can harbor bacteria, molds, and things like that. So it's really important to clean those. Then we have vaginal medications. These can come in a variety of dosage forms, including suppositories, tablets, etc. These are either typically used to treat local infections, or we can use them for contraception, potentially, hormone replacement, a lot of different reasons for that. And most of the time, patients will either use this themselves because it's over the counter. We frequently tell them to use it at bedtime. That's mainly because that way they're kind of not up and moving about, and can cause the medication to kind of leak out early. Given a bedtime when they're laying down, it's usually going to help to keep the medication in place better. So that's it for this section for percutaneous administration. If you have any questions, let me know, and I'll talk to you soon. Thanks. Bye.